Now Dr. Ravi is ready with his presentation.
Good afternoon, respected faculties, chairpersons, moderators, and of course Dr. S. Prasad sir for giving me opportunity to present a case here. Slide आगे इससे So I am presenting a case of 50-year-old male female presenting with a pain, limping, instability in her right hip. Patient has a history of intracapsular fracture neck femur 30 years back. For she was operated as McMurray's osteotomy. A long term back there is McMurray's osteotomy, that is the medial displacement intertrochanteric osteotomy done for the fracture neck femur, intracapsular neck femur. So this is a case. The clinical signs are the proximally migrated femurs, shortening of approximately 6 to 7 centimeter. There is flexion, adduction, and external rotation deformity. And there is a deranged anatomy of proximal femoral in both coronal and sagittal plane. Telescopy is positive, and distal neurovascular system is intact. So planning for this case for THR, CT was done, and you can see CT in the axial section. There is non-union fracture neck femur, the proximally migrated proximal femoral, that is disturbed anatomy in both coronal and sagittal plane. This is the 3D reconstruction. You can see well where is the GT, and all about the neck is absorbed. Adduction is there. So what are the challenges for this case in the THR? Whether we approach anterolateral or posterolateral, the previous scar is there. Implant, what we can use, cemented or uncemented, uncemented cup, pinnacle or duralock, that metaphyseal. There is a defect, is the problem is challenge in the shaft of the shaft side, so it's the femur side. So the either the metaphyseal coral stem or their diphyseal stem or their modular stem, and the challenges in the reduction technique. It reduce with osteotomy or without femoral osteotomy. We have to do a trochanteric osteotomy or trochanteric advancement. Stability, dislocation, range of movement, adductor tenotomy, shortening, and of course the osteopenia and osteoporosis because of the long-term fracture neck of femur. So these are the challenges while doing the THR. So we did the pre-operative management. Heavy skeletal traction was given for 15 days because the telescopy was positive before the definitive fixation. So this is her traction view. You can see some changes before this, before traction and after traction. But the anatomy of the proximal femoral is deranged in this view also. So we plan uncemented THR. We plan the duralock cup of size 50. Of course, we use the modular stem in this case. This S-ROM modular stem was used. 40 degree of antiversion because the native antiversion is deranged, and 36 mm regular offset with minus head, and reduction was done without femoral osteotomy. Of course, the adductor tenotomy was done, anti-capsule was released, ELOSOS and GMAX was released, and soft tissue is majorly released to bring down the head to reduction. And there is a in the post-op X-ray you can see the abduction is achieved. But unfortunately, the intraoperative complications there is reaming. While the reaming of the acetabulum, there is a breach in the acetabular floor. So we are not prepared for that floor, but the impaction bone grafting was done. That had taken out from this, and screw was used in the Duralock cup. So this was the modular stem. S-ROM stem was used. The post-op, the intra-op hip was stable with good range of movement. Residual shortening was approximately 1 to 2 centimeter. No neurovascular deficit. The patient was no weight bearing allowed, only sitting was allowed, and active physiotherapy of quads and abductors. Thank you, sir. This is
good procedure. Could you show us the pelvis X-ray, please? Post-op, full pelvis. No, full pelvis.
full X-ray, sir, not there.
So that is very
Yeah.
important. So what has happened is,
Yes.
just a critique, because look at your greater trochanter
Yeah.
and look at where the center of the head is. So
Yeah.
your sizing, there was a problem. It's sunk
So
down.
some sinking is the
And
stem.
so there will be a potential for impingement. If you go back to the pre-op X-ray, please go back to the pre-op
Yeah.
X-ray. Yeah. So this is a case where it's almost certain that you would require at least some sort of shortening osteotomy.
Yes.
So I think how you get on table, you do not realize how it sinks down, and then you get a reduction and you're led to believe that you've got the reduction.
Yes.
So that is why, as a rough rule of thumb, on table you have to look at the center of the head versus the top of the GT. If you've gone below that, that means your stem has sunk.
Sir, I have tried that high offset stem also in the.
No. High offset will not solve the problem. If you understand what I'm trying to say, it's not the
Yeah.
high offset. It is a problem that your length, your proximal high riding hip has
Sir.
not come down. So
Yeah.
that will only be possible with that's why I asked you for the pelvis with both hips.
No, sir, the S-ROM has both variant. The high offset
No, it's
stem
not
in the
the
same,
implant. It's not
same,
the-
same.
no, no.
Yeah,
It is not the implant.
Yes.
If you go to your post-op X-ray, your implant S-ROM shoulder should have sat just within a centimeter or just at the tip of the GT. You understand what I'm saying?
Yeah.
So that means it would have been a very tight reduction. And that's probably also, your reduction was also aided by the fact that you medialized the cup a little bit.
Yeah.
You understand what I'm saying? So all these factors led to you to believe that you probably got it. So this would have been avoided, or this could have been a better outcome.
Yeah.
If
there
you
is-
had,
there is
so
also-
because what was the size of your S-ROM? You could have definitely gone to one size more.
Yeah.
How tight was your S-ROM fit?
S-ROM is snugly fitted, 12 mm size.
There's no 12, there's only 11. 11 and then it is
Sorry, 11 mm.
11 and then 13. So
11 mm. 11 mm.
11. So you probably could have judiciously gone to a 13 and done a shortening osteotomy, because your sleeve is also sunk very low. And so this is going to have room for impingement because there is still a high riding hip. Otherwise it's well done. Because the thing is also the fact that when you're looking to restore this, you're trying to restore the proximal femoral migration also.
Yes.
And this is sunk in, and that is what will happen is delayed impingement. That is a problem.
Yeah. I compensate this shortening for some sinking is there. Yeah.
And besides impingement, I think abductor efficiency will go down, more joint reaction forces. So he's being critical. What would be the ideal scenario?
Yeah.
He's being critical of what should be the ideal scenario. You could get away with low entry, that's okay. But what he's trying to tell you, try to bring the trochanter low at the level of center of the head. So the abductor efficiency also improves, joint reaction force improve, and the longevity of implants improve. This is what he's trying to tell.
I want to say that if we have used this minus head, if we using the plus head, we can increase the length and offset both.
It is not in the implant. Okay. Yeah. See, for instance, your preoperative traction won't have helped you at all. That is not. It's a question of getting the release and getting the hip down. So that is what is important. So using a plus head in given this case, you can sink it more and use a plus head. You understand what I'm saying?
Yeah.
So that will not solve the problem. The problem is restoring the horizontal offset.
Yeah.
And that is what has actually not occurred because it is sunk down. And because of that, your abductor resting length will come down. And because of that, you will have an abductor fatigue as the patient continues to walk more. So it is important in these hips to restore the abductor resting length.
Thank you, sir.
And the dictum is, if your lesser trochanter is at the lower level of a sternum or higher, be prepared for shortening. Be prepared for that.
And another advice for all the presenters, including us, always when we are showing a post-op result of a hip, it should be shown
Yeah,
with the
both.
pelvis with both hips.
Yes.
That is standard protocol all over the world.
Thank you, sir.
Thank you very much, Dr. Ravi. Thank you. It was a difficult case.
Thank you, Dr. Ravi. Now I call upon Dr. MC Saini leaving. Just, we would.
Great round of applause for him. One of the keenest observer I have ever seen.
We learned so much from him.
Thank you all. Thank you for.
I'm pretty sure he will
Hello.
change the practice, how you operate, his statement, his presentation and his saying will change. It has even changed my practices. So we all learn from everyone. Thank you, Anil, for being here with us.
Thank you so much for bringing me here. And thank you. Like we said, we also learn every day. We also are learning every day. I've been coming for this Kanpur course for the past several years. Thank you, Dr. Prasad, for inviting me. And it's always been a pleasure to come and interact. Thank you very much.
We'll keep troubling you year and year again.
Best to identify the bone stock, any collection, what is the bug, what is the bacteria. We would like to give antibiotic accordingly, otherwise you will give it empirically. You will try to cover thoroughly and you will give it empirically. You will become more wiser.
In infective cases, sir, I believe better is debridement, curettage. My opinion, as the tumor, we as operating the tumor tissue and dealing the normal tissue, and when you excise the tumor tissue, you have to take out at least 5 mm or 1 centimeter normal tissue. The same thing I try to.
No, here that principle does not apply because there is a cavity in the acetabulum, infection in the bone. You are not taking it out. It is there. You are not gone inside the bone, isn't so? We cannot go every nook and corner microscopically. Number one. Number two, whatever you debrided, whatever you got, did you send it for culture? If yes or no, if yes, then what were the bacteria? Because it's a very sensitive case.
I sent the cultures in this case also. I sent the culture and the antibiotic, will start the antibiotic according to the culture sensitivity.
So what were the bacteria? That's very important. Again,
Staphylococcus.
Staphylococcus aureus. So it was an active osteomyelitic process we performed this. And then post-operatively, what antibiotic and how long did you give?
I prefer the injection Dalacin and Miro SB injection, Miropenam and subluxum combination. And one antibiotic, rifampicin also given the 450 milligram OD.
And how long did you give it?
3 weeks. Injectable for 10 days and followed by orally tablet.
Oral for how long?
3 weeks.
Yeah, see the consensus is to give it for a long time. For 3 weeks osteomyelitic process with staph, we would be able to vary. In our practice, we give it for a few months rather. We are talking of oral rifampicin. It is a relatively safe antibiotic. Rifampicin can be given for a few months. And did you monitor with hemogram, ESR and quantitative CRP? Because 3 weeks is very less time to come to know CRP coming down post-operatively or post-infective. Very difficult to make a decision.
And sir, there is also a lot of, in this case is the osteomyelitis case, but in case of periprostatic infection, so many, I think, done in single stage surgery, even the periprostatic infection, and only the basis of debridement, proper debridement, and do the single stage surgery.
Here it's an
There are a
osteomyelitic
lot of
process
studies there.
in the bone. It is in the bone. It is absolutely different story. Yeah, God has been kind to you and the patient both, but we are talking of principles here.
Just
one question to
it is
you.
a very interesting case and your outcome is looking good, but the path is not very clear to us.
Principle study.
The path is not very clear. You have not been able to show us the path, how you have done it. the X-ray quality was not good, and you said you were taking weekly X-rays after debridement. What was the aim of weekly X-rays? You mentioned it in your slide.
Weekly
Which
X-ray to see the pull out, pull down traction, how much pull down the trochanter, so that reduction make it easy during the time of surgery.
And any idea about the pillars of the acetabulum, how they have eroded? You don't have any idea. That again you will go and see. So, because you have not been able to show anything pertaining to how acetabulum was eroded. In your presentation, we could not see it. Yes, your case was intriguing, very, well, it evoked a lot of interest initially. The result looks good, but the way of achieving it is not very clear. That's only my comment.
He has a question to ask me. Yes, please.
Yes, sir. Usually, if we have even a slightest of infection, we do spacer and then come back and do the second stage.
Yes.
So, would you suggest going in the same way in this case, or I think you got one way?
No,
one
two stage. One was debridement, traction,
Okay.
IV antibiotic, and then second stage.
That's right. No, sir. Message. Should we put spacer in and then come back after 3 months?
Oh
and
yes,
that's what we
spacer
do.
is must.
Yes, that's what I
Spacer
wanted
is
to
must to control any osteoarticular infection in which you are trying to put an implant later on. You need to give 100 times higher concentration of antibiotic which you can give systemically, and that is possible only by spacer.
And we can add some stimulant also.
And
along with
spacer will serve the purpose of maintaining soft tissue length besides delivering local antibiotic. So a lot of things. So we are talking, see, he had his own way of doing it, but we are talking here of principles, how to do it.
Yeah. So principles include spacer and then.
Oh yes, 101%.
That's right. Yeah.
101%.
A question.
That is for bone, yes. For bone.
So question to both of you, sir. Firstly to the speaker, sir. At what was the time, what made you decide to go for the second surgery, the time duration? Was there any marker you fixed?
Marker,
Or any parameters
yeah, in
that
fact,
I'll go for the second
blood.
surgery after this?
I use the blood marker, especially CRP, SR. When it comes down normal, then I decide for surgery. And second thing, when you see the position of trochanter on the X-ray, serial X-ray.
You found active infection in the first surgery.
Yes.
You
Yes.
found Staph aureus there.
Yes.
And what made you decide? Any parameters you fixed that this will be quiet after this time, whether ESR will come down, then I'll go for the second surgery?
I
you
only
decide?
blood markers. I use only blood on the basis of blood marker. Then I decided for the second stage surgery.
Second question to Anil Arora, sir.
Yes.
Sir, normally we use a spacer antibiotic, the pre-made one. So, what antibiotic would you prefer? You add extra antibiotic to that spacer, whatever is inside the premix that you get. Do you add extra antibiotic or?
So I do add extra antibiotic, vancomycin and gentamicin,
So how much?
both of them.
How much, sir? What is
So 20% you can add, 20% of the weight.
over and above whatever is inside the mix?
So I get gentamicin and semen, and I add vancomycin that and some more gentamicin. Vancomycin 20% upper limit of per grammage.
It has nothing to do with the body weight of the patient or
No.
only
That's
20%
right.
is the upper limit.
Upper limit, that's upper limit. One more case. So thank you very much. Very exciting case. Lot of discussion inside it. Whatever cases are being presented here, everybody will have to scratch his or her head to discuss.
A very good afternoon, respected chairpersons, faculty members, delegates, and a special thanks to Prasad sir and team members. I am presenting a case of infected modular bipolar, a two-stage surgery. I am presenting a case of infected modular bipolar, a two-stage surgery. My patient was presenting in OPD with discharging sinus over posterolateral aspect of the thigh and pain in the left hip. This is initial X-ray of the patient. This patient was managed somewhere else 6 years ago, and this was the initial X-ray of the patient. And this was the X-ray when I was done workup in my OPD. Showing infective foci over the tip of the stem. And protrusio at the cup. I was go through the workup and blood investigations of this patient, showing TLC raised, PSR raised, and CRP was also raised in this patient. So sinus is present, infective foci in the radiograph, and blood marker is also raised. So I am suspected a clear case of infection in the prosthesis. So this is the pre-op radiograph of the same patient. Planning for 2-stage surgery. In stage 1, we are planning for implant removal and spacer placement in the same setting. This is pre-op pic of the same patient on the day of surgery, unable to squat. First, I was removed the implant. We are bit difficult to remove the implant because of osteophyte and bone encroaching around the cup. This is the implant removal, modular bipolar. And in same setting, we are placed gentamicin antibiotic spacer in the same setting. This is spacer placement. This is immediate post-op radiograph of the patient after spacer placement and after 6 weeks of follow-up, showing sign of healing on the radiograph, and blood markers are also improved. CBC within normal limit, ESR within normal limit, CRP within normal limit. Sinus completely healed at this stage with no active sign of infection after 6 weeks after implant removal and spacer placement. Then we planning for second stage of surgery. In second stage of surgery, we are planning for spacer removal and definitive surgery in the form of total hip replacement. Spacer removal was done in the second stage after 6 weeks. Definitive surgery was done in the form of ceramic on poly with hybrid stem, antibiotic cemented stem in this patient. This is immediate post-op after second surgery and after 6 weeks of surgery. post-op radiograph after 6 weeks of surgery of the same patient. Post-op video, sorry. After 9 months of follow-up, this is the radiological picture of the same patient with no active sign of infection, with no sinus, and all blood parameters are within normal limit. CBC, ESR, CRP are within normal limit. And this is 9-month video of the same patient. This video is of last Wednesday. I was using posterior approach. After posterior approach, my patient was doing squatting, sit cross leg. After 9 months of procedure, all procedure were done. Sit cross leg, squat, all positions. This is abduction on the operated side. This is scar. This is scar after 9 months of surgery. The sinus is already healed. These are fixed. Thank you for patience hearing.
Aspiration was done, aspiration and culture.
Initially, the patient was presenting a sinus over the posterior lateral aspect of the thigh. So we send the culture from the sinus side.
Okay.
And blood markers are already raised, and there is infective foci already seen on the radiograph.
Okay.
So we are directly focused on this is the infected case of the modular bipolar.
Okay. After putting the spacer.
No. Initial sitting.
Initial sitting.
First presentation.
So, first question, why was bipolar done in this case to begin with? Index surgery.
No, the bipolar was done somewhere else.
For?
For maybe some head of fracture or some kind of patient is 25 at present. And when the bipolar was done around 19 or 20 years of age. This surgery was done somewhere
That's very
else.
surprising.
Very
Maybe for a tubercular lesion, for any lesion it might have been done. Surgeon must have thought.
The first surgery was done somewhere else.
So now a few questions to you, sir. Because this is an infected case again.
Yes.
Now, tackling infection, and we were lucky everything went very well. What was the culture when you took intraoperative cultures?
Yes, sir.
What was the culture?
Yes, sir. Initial culture from the sinus side.
See, one thing I want to make it clear.
And
The
one-
culture from sinus is fallacious. You will get polymicrobial infection because it's exposed to the environment. So we just can't rely, if you go by textbook recommendation, sinus culture doesn't carry much value.
I was also taking intra-op culture in
Yeah,
first
that's
sitting
very
and
important.
second sitting also, in both settings.
What were the culture reports?
Staph aureus was the organism sensitive to the cephalosporin, sulbactam, linezolide. So we are continue the antibiotic for 2 weeks, cephalosporin, sulbactam and septum and linox for next 1 month while putting the spacer.
And two questions. How long did you continue antibiotics total overall?
Total 6 weeks, sir.
Only 6 weeks.
2 weeks for IV antibiotic.
After second surgery?
Second surgery after 6 weeks.
And then no antibiotic? Antibiotic?
No. And after second surgery, we continue on the sensitivity, cephalosporin, sulbactam.
How long?
So after second surgery, we are also continue for 2 weeks IV antibiotic.
And that's all?
Then oral antibiotic also continue for linezolide for around 1 more 2 weeks. The long duration of antibiotic in this patient, we kept very long duration of antibiotic.
This is what you want to know, what long? This is what you want to know. After second surgery,
6.
total duration.
Total duration 6 weeks, then 2 weeks in up to stitch removal, then at least 2 weeks more, 2.5 months at least.
You mean to say 1 month post second stage?
Total 2.5 months at least.
2.5
We kept at least 2.5 months.
6 weeks prior to the second stage and then 1 month
1 month
after the
along
surgery.
with antibiotic spacer, then at least for 1 month after.
Both the cases we saw infected, very short course, but fortunately both are healed well. The convention is different. Convention is to give for a long time. There's a convention. And I think in spacer, you added only gentamicin, nothing else, no?
Well, this is ready-made spacer.
Ready-made
in
spacer.
which gentamicin already impregnated. So,
And was it sensitive to gentamicin?
yes,
You must have got culture report
Yes,
because
sir, yes.
gram-positive staph,
and sensitive.
sensitive gentamicin,
Yes, sir.
very lucky situation there.
The effective,
Sensitive.
there is no active sign since 9 months.
And going by first X-ray, there was area of destruction, the diaphysis.
Yes, sir.
We did not use a slightly longer stem, bypassing that area. We again used same
Yes,
almost
sir. Can
short stem.
bypass this area.
We should have bypassed that area, no?
Can we added this?
See the stem or the diaphysis of the femur, we have got clear-cut bony reaction at the tip of the failed bipolar or infected bipolar. So that area is a vulnerable or a stressed either point. That should have been crossed. Now the cement restrictor is at the same place. So which is a foreign body. So the little question mark is there. But anyway, he's lucky as far as the result is seen. But it is a very short-term result. So even he should keep his fingers crossed.
Yeah, recommendation is to bypass that area.
We
Because
kept the
that's,
patient in close follow-up.
but you know, you have to, once you have reached that area, you can't extend that stem. So in revision surgery, whatever you did, you should have bypassed. That's the recommendation. To bypass any weak area, infected area, vulnerable area, we have to cross that. Any other question?
I think the sequence of events was good. The presentation was in the right format. The only thing, I still think a youngster should read more. The literature about these things are very common. The infected implant we will see day in, day out. So I would just request everyone to read little more. What are the changing scenario? Because things will change. Our science is dynamic, so the guidelines keep on changing. So just keep abreast of all what is happening. And infection is very important. So just, otherwise it was a great result and good collection of photographs, good collection of X-rays.
Thank you, sir.
Nice presentation.
Thank you very much.
And the cemented spacer and antibiotic bead. I have done a lot of cases. In that cases already infection में ये डाले गए और again infection develop होता है. After removal of these antibiotic beads and cement, then patient will become better. I deal at this lot of cases in this kind of whereas antibiotic beads are putting and cement is putting, and when I treat only that cases after removal of that this thing. So that is a controversial.
We will answer that. We'll answer.
I think, okay, I'll just say, what you are saying may be true because you have seen it. The antibiotic beads or cement is not something which will 100% cure the infection. But this is one of the ways to do it well. You may not do anything you can give the Ayurvedic and the patient can heal. So that doesn't, we have to go with the law of averages, what usually happens. I may have done around 20 beads and couple of them once I had to remove and do a repeat debridement 2 times I think. So that this keep on happening. But you cannot say this doesn't work. If it out of 20 in 18 it works and in 2 it fails, still it works in majority of cases. So, and that's why the field is dynamic, the guideline will keep on changing, the antibiotic protocol will keep on changing, but the tools we have a cell studies, the intraoperative cultures, different areas which can be cultured, and in your case, Dr. Sani, it was a clear-cut case of osteomyelitis. The case which Dr. Rajput just showed, it doesn't show any osteomyelitic changes in the bone, it has infection. So this infection and the case you showed, that infection is poles apart.
Let me answer your question further. These spacers for antibiotic beads will keep on eluting antibiotic for a certain period of time. If you cannot control infection by that period of time, what Dr. Prasad said, you are supposed to repeat them. Our patients, once you put spacer, maybe they will not come for 4 months, 5 months. That doesn't mean that it will keep on eluting antibiotic. It has a limited period till which time it will elute antibiotic. Do the next step within that period. Either repeat debridement or surgery, which does not happen. Practically speaking, if I debride one patient and after 6 weeks I tell you debride again, he'll leave me to some other doctor. Doctor is not correct. ठीक नहीं है doctor, कुछ और किसी के पास जाते हैं. Science will not change. Patient perception might change. So it is must, paramount, to control infection. Local high concentration of antibiotic is must, absolutely must.
Yes.
That can only be achieved by spacer. There is no other way.
And in infection, nothing is foolproof. Nothing is foolproof. It doesn't mean that if you are wearing a helmet is not mandatory. Wearing helmet does not prevent the head injury. That means that is a part of the truth, but it prevents the head injury in most of the cases, and that's why we follow that. That is the basic thing.
And spacer in itself is a science, believe me. What antibiotic, how much to add. There are few antibiotics, if you mix them, elution improves. There is a way to make a cement spacer. You make it poor. You don't make it a good mixing. So elution changes. There are a lot of studies on this.
I think we decreases the probability of reinfection. After doing all these procedures, we decreases the probability of reinfection. Once an infection, then maybe in future, already if a quiescent infection, there's very high chance to reinfection in future. But by doing all these procedures, we decreases the probability.
Yeah. Thank you, Dr. Rajput. It was a good case.
Thank you, Dr. Rajput. With this, now we come to the end of and catch hold of experts for any of your doubts, queries. All are here.
Yes, kindly be with us for 5 minutes. Our star performer, Dr. Prasad, is coming just now. He has gone out for some emergency purposes. Now, there are many people and everybody has presented so nicely that it's very difficult to sort it out. But ultimately, we have to go through the data. The one prize goes to Dr. Anup Agarwal, one of my most charming friend. I'm not biased. I'm going through the data. That's why I'm saying. Second is Dr. R.P. Singh. And for the third prize, there is a catch. For the third, there is a catch. My blue-eyed boys, I am going through the data, that's why I am saying perpetually. Dr. Manish Trivedi, yes. I think these are all, except Anup Agarwal, all my blue-eyed boy. He is my colleague SI, I can't say anything to him. But still, very nicely done, very nicely presented. Dr. Prasad, sir, your blue-eyed boy got the prize, that's why I'm saying. Aditya. I'm going through the data, there's a tie between Aditya and Manish. And one goes Anup Agarwal, and third is RP Singh. हमारा अनूप अग्रवाल. That's why I'm going through the data. I think these fellows, yes, come have a photograph with all these four guys. They have done beautifully. यही था. संजीव आ जाए. That's a good thing, and that's the tradition. Dr. Arora sir, without your photograph, the place is vacant, kept vacant for you. No sir. सर हम लोग फोटो खिंचा ले, इनकी तो उम्र पड़ी है.
Dr. KD Tripathi, please come.
एक फोटो हमको भी खिंचवा लो यार मेरे साथ. मक्कड़, अरुण लाल आ जाओ भैया तुम लोग. बॉस आप लोग कुछ तो आशीर्वाद दे दो हमको, कुछ तो हमसे सीनियर हो. अरुण लाल बॉस एक बार आ जाओ बॉस, आशीर्वाद दे जाओ. इतना हड़काया रहा तो आशीर्वाद भी दे दो.
बहुत बढ़िया है
हमारी इतनी रैगिंग की इन्होंने.
हम लोग से बार हो गया, इतना बढ़िया हिप रिप्लेसमेंट करके आए. डॉक्टर अरुण को दिखाओ, मैं तो तुम्हारा दोस्त हूँ, ये अच्छी बताएंगे.
Just have.
सच में दिखाओ अरुण.
And this is the war. And I think we'll keep on meeting in future. This is almost all the thanks to all the delegates and all the faculties. It's been nice enough to interact with all you people. And we keep on interacting, and doesn't mean that is only the one affair. This affair will keep on every time. And it will not possible without the support of you people and the input of you. Whatever you think negative even about us, will be delighted to hear about it. So that we should make it better next time.
And keep on operating. Luck favors the brave.
Yes.
So we have seen many cases where luck has favored. Dr. Saini's case is one of such cases where luck has favored light. Then another case, Dr. Rajput also, he has done a short stem, might fail but might not fail. That only time will tell.
Right. हम वो नहीं जो मतलब से याद करते हैं. हम जो वो हैं जो रिश्तों से प्यार करते हैं. आपका पैगाम आए ना आए, लेकिन हम आपको हमेशा याद करते हैं.
So keep on operating. Ultimately, everyone does if I have to recollect, I remember all my mistakes which I did.
हाँ जी.
All the good cases you will forget, but all these small things, they will, the trouble in the night. हमको भी करता है, सबको करता है.
It's a great honor for us also that he is with us. There are certain people who bring the positive vibes to our conference, and you are one of them.
ये होता है ग्लैमर ना.
एक हिंदी में कहावत है, अपने लिए मियाँ मिट्ठू. केवल ये चाहते हैं एक बार हमारी टीम के लिए भी तो आप लोग तालियां बजाते हैं, जिससे हम अगली बार अच्छा करते हैं.
पीछे वालों तालियां बजा देगा तो देखते रहना.
हमारे लिए भी आप लोग तालियां बजा दें, जिससे आपकी और अगली बार हम अच्छा कर दें, कम से कम हमें भी तो इनकरेजमेंट मिले।
See, every year when I come, I see more and more complex cases here, believe me. And that shows the kind of education going on in this area. You need a lot of conceptual thing, principles, clarity of thought to harp upon these kind of surgeries. These are very highly specialized surgeries. And kudos to these kind of courses, you know. They are so popular. And somebody was telling me that UP trauma course is going on and there are more delegates here than trauma. It requires a round of applause for this. Believe me, this shows the popularity of course, and this shows long-term vision of Dr. Prasad. Beautiful. That's right. That's it.
That was 5 years back, it was unheard of. I will not dare to do that.
They would refer.
Everyone is daring and getting very good results. Right?
I remember the days when 90s, only osteomorph processes and bipolars were being done, and then cemented bipolar came, and then all the cases were going to the Delhi and Mumbai, and it was joint replacement was the surgery of classes. But let it go to Dr. Prasad,
yes.
that for last 15-20 years he has done tremendous effort to make it to the surgery of masses. And now it has gone to the masses. Every nook and corner of UP is doing the surgery.
See, the best part is they are not routine cases what they show here.
He is the man behind that.
Not routine cases. Even you will scratch your head to put a plate on in a acetabular fracture. Just put the cup. Just put the graft and cup. What do I do? Is it stable enough? And very good results.
See the cases in the Raebareli.
Yes, beautiful.
Periprosthetic fracture. It is just let it goes to him.
See, even in Wagner stem.
He has encouraged the young doctors.
Yes, to learn how to make it stable.
I'm there to support you online, offline, wherever you want.
Beautiful.
He is the man to support you.
So a round of applause for him once again and for the whole team. For the whole team, I see this kind of cohesive team organizing course year after year. At least I have never seen. Beautiful. और आपके शेर तो एकेडमिक्स में जान डाल देते हैं।
जी हमारा कोच
क्या बात है।
केजी त्रिपाठी डॉक्टर अमित वर्मा की टीचर है। क्या बात।
ये लीजिए।
माइक का चेक देखना पड़ेगा।
नहीं ये वेबसाइट पे रहता है भाई, नहीं वेबसाइट पे रहता है, यू हैव टू विजिट वेबसाइट। That's all photographs, all the conferences, all the workshop there, it's there.
बाद में 3640 and 40 अभी डिसाइड 40 चेंज करेंगे वर्टिकल तो फिक्स हो जाएगा। अभी मेरे पास ऑफसेट क्या होता है?